lunch. Thank you for coming back. So delighted to start this afternoon with a presentation from Professor Catherine Payne, who was meant to be this morning, but delayed because of the trains. So she'll be speaking about some approaches to health economic evaluation in pharmacogenomics, and specifically talking about how her and her team have approached this around progress. So thanks, Catherine.
Yes, apologies. Thank you, Avanti, Northwest. I hope I've got enough time to fit in what I want to tell you about. So we've spoken before about some of the work done by myself and colleagues at the University of Manchester that's been done alongside the Pharmacogenomics Network of Excellence. Sean Gavin presented the asthma work previously, and today I want to tell you a bit about some of the clopidogrel work we've been doing, but also some initial results when we've tried to look at the cost effectiveness of a panel test in primary care, which for a health economist is not for the faint-hearted. It is quite a challenge. So I'm going to talk you through what we've tried to do and tell you where we've got to so far. So I always like to show these. So back in the day when we used to actually have hard copies of medical journals, you see on the back pages these smiling pictures of people on medicines, and they're all really happy. And then I found this ages ago, and it was this little thing that says, I think the dosage needs adjusting, and not nearly as happy as the people in the ads. And I always use it when I start to talk about pharmacogenetics, because I think it basically summarises the issue quite well. So when we talk about what is a pharmacogenetic test, I'm at fault of doing this myself as well. I use shorthand. It is actually a complex intervention that can be delivered in a myriad of different ways. And I think when you start to look at any analysis, including economic analyses, you've got to be very clear about the assumptions that were made about how that test has been delivered, from the point of actually where the service was located, to whether it was looking at a single medicine gene, multiple genes, whether it's reacting to when the medicine started or it's been done in a preemptive way, how the sample was collected, where the testing was actually done itself, how the test result was returned, and how the data was stored. All of that will affect cost effectiveness. But you will see when I start to present in a moment, I'm going to assume you know all of that, because I've only got a short amount of time. But it does affect cost effectiveness, and we've got some nice examples of that happening. So I also use shorthand as well. So when we're talking about cost effectiveness, it's sometimes synonymous with value. What do we mean by value? Health economists are very specific what they mean by value. We mean we're considering opportunity cost. In English, that means that if you spend some money on one thing, a pharmacogenetic test for a population of people, you can't spend that same money on someone else. So there's an opportunity cost. And we measure that using cost effectiveness analysis, where we say, okay, we've got this new shiny thing compared with what we currently do, and we look at how much it costs the system, maybe the NHS, and we look at the difference in the health of the people who get the new shiny thing and get the thing that's currently, or the thing that's currently being done. So then we look at the difference in these costs and the difference in our health, and we measure them using life years that have been quality adjusted for how good those extra years of life are. Those are our QALYs. So then we have to say, well, what do we mean by value then? That cost effectiveness in itself doesn't mean anything. We use a threshold. At the moment, we use the NICE threshold. Has anyone been looking at the news? Who knows what the current NICE threshold is? No one does. No one does. So, yes, there's been discussions about that. We're standing firm at £20,000 per QALY at the moment in the health economics community. Let's see where we end up with that number. But you will see today that's kind of it's a non-issue when we start to look at some of the evidence for cost effectiveness, which is a good thing. Okay, it doesn't matter how you set that threshold at the moment because it's looking very good. Sorry, that was a kind of a preamble to the results. If you look at them, there's a number of published cost effectiveness analyses of pharmacogenetic tests. The majority are focused on single gene, single medicine examples. You do see, if you start really interrogating these literature though, different findings. And that is based on the varied applications, the different jurisdictions in which you will deliver those tests, and different assumptions. So it isn't barn door obvious that they are going to be a cost-effective use in clinical practice. And if you look at some of these cost-effectiveness analyses, really try and dig down into those assumptions that have been made. I wanted to just whiz through this, where this was one piece of work that was led by Alireza Mahbub Harari, and he worked with Joe Hilton looking at the cost effectiveness of a pharmacogenetic test to guide antiplatelet therapy, specifically looking at people who needed antiplatelet therapy for acute coronary syndrome undergoing percutaneous coronary intervention. So Ali and Joe developed a model, and they used this model to represent the pathways of care if you had CYP2C19 guided testing compared with how dual antiplatelet therapy was currently prescribed in practice within a hospital setting. And so we looked at the perspective for NHS England, and we said, right, we're going to test these people and then follow them up for life. Importantly, in our analysis, we accounted for imperfect uptake. Imperfect uptake in terms of people ordering the test and then subsequently following the test results. And a lot of cost-effectiveness analyses don't do that. They assume perfection. They assume everybody does as they're told. And we know, if nothing else, clinicians don't always do as they're told. I'm safe. I'm not going to be shot at lunch because I can run out the back. So, yeah, we assumed a nice 93% rate, which we took from John McDermott's work, where he looked at preferences for pharmacogenetic testing. So that's not a real uptake figure, that's one that we assumed. So we looked at two separate populations, so we had two separate models. So we looked at STEMI and NSTEMI with unstable angina. And within each of these two analyses, we assumed a distribution of the number of men and the age within each of those populations. So this analysis is very specific to people of that age and that population. So if you're generalizing from the results, you have to think, does this represent what the type of patient I might see in clinical practice? So these are the results. So what you really want to look at is the right-hand side. And so what we've got on this table is we've got two rows. So we've got our STEMI population and an assumed distribution of whether they're given clopidogrel, ticagrelor or prasugrel for the STEMI population. And you can see that distribution of medicines is slightly different for the unstable angina NSTEMI population. And then you can see as you move through this table, you've got the cost of what would be done if it's current practice, the cost if you test, the cost difference with a typo. Always a pharmacist that can see a typo from 100 paces. You've got your quality adjusted life year for current and your quality adjusted life year if tested. So this is barn door cost effective. So you've got a number there of £569 per quali gained. So compare that to your £20,000 per quali threshold. It's nowhere near it. It is a cost-effective thing to do. Now, it's slightly higher number in the unstable angina NSTEMI population, around £2,290 per quali, but again, a cost-effective thing to do. So in this population, we're showing here that using pharmacogenetic testing in this context has a high probability of being cost-effective. Key drivers, if you want to be quibbling about, well, when might it not be cost-effective, if you start looking at the risk of ischemic events and utility values, so when we look at people in particular states or health states, we attach a number that represents their quality of life. That's what we mean by utility value. And also if you start playing around with reinfarction rates, the risk of a major bleed, and again, the utility values for unstable angina and STEMI. If you play around with the assumed cost of medicines, because we've had people querying that, say, oh, well, ticagrelor is a lot cheaper now, so, you know, it might not be cost effective. If you play around with that, doesn't matter, doesn't change the result. So this is good news. It's a nice good news story. What I'm here to talk about today, though, is panel testing. So we've done a rapid review of the literature to try and assimilate some of the evidence base on the value of pharmacogenetic panel testing. You see on this slide we've got three studies. These have looked at, if you like, sort of hypothetical examples, let's call them that. They're not actual analyses. They've done a very good job of trying to create a scenario where you start to begin to look at the value, but they haven't constructed decision models and followed them through. Now you can see if you look at the graves in the US, so the X's mean not good, not cost effective. The ticks mean it was cost effective. So Catherine with Duffrig, so Catherine Hughes with Duffrig showed that this was a cost effective thing to do. They took an aggregate approach. They basically went out and looked at the number of different medicine gene pairs and summed qualies and costs from other studies and did a nice mathematical sum and summed it together and said, yeah, this is a good thing to do. Other people have looked at panel tests in specific diseases. So you can see the top one there looked at, it was a multi-gene test for post-PCI in acute coronary syndrome. And then you've got examples where they've looked at anti-epileptics. You can see there the majority of these are ticks. There's a couple of crosses on there. Some of these were decision models. They've relied often on large prospective studies where they've basically used the model to simulate those prospective studies. So the challenge might be in some of the follow-up of some of these data. So it's the extrapolation to the longer time horizon. But on average, these are, you can see, are looking like a kind of good thing to do. Sorry, this is tipped off the edge of the slide. So I was given, so I started working with Bill and John on the progress study, and we started to think about how we might conduct an economic analysis for the panel test that was being used within the progress study when it was being rolled out in primary care. And John's hopefully already explained this to you about how they've focused on a specific number of medicine gene pairs within the potential for this AGENA assay. So the AGENA assay has got the potential for 20 genes, but within progress they only focused on 3. Even to conduct an economic analysis focused on those 3 is a challenge. And so what we wanted to try and do is construct an analysis that looked at the incremental cost of the NHS and the health consequences of rolling out a test that's reacting to a medicine being prescribed in primary care, and those data are then subsequently available for reuse for subsequent medicines that are used in primary care. And that's what we wanted to try and do. We wish we hadn't started. Trying to be all positive. The train ruined that for me this morning. So we defined our PICO, so we defined our population. So we had to imagine a population, so we said, right, let's start with people, a nice age of people who are likely to need medicines in primary care, 55, split equal men and women within our population. We're going to look at this in a cohort way. So this is not an individual level model like some of the ones we saw before, it's a cohort. Progress is brilliant, but it doesn't give us the data we would need to do an individual patient level simulation. We just don't have the data required. So we're going to model this cohort. We're going to assume an average general practice has around 7,800 people. Thanks to Jude, I think Jude's in the audience, we used a lot of her insights into constructing our general practice. And then we're going to focus on two examples, management of moderate depression and management of primary prevention of cardiovascular disease. And within our 7,800 patients, not all of those are going to need medicines for these 2 conditions. So the first bit of data we need out of our general practice population is how many of those are starting one of these medicines. Jude gave us a guess. This is a guess. So we've assumed 370 people are on medicines for depression, and 800 are for cardiovascular disease. Now, it kind of makes common sense. Everyone thinks, you know, statins are given out like Smarties, so you might assume it's all 7,800, joke. But it is a higher proportion are likely to be on a statin than a medicine for depression. The first analysis, and the analysis that we're going to present today, is we're assuming that they're going to start one of these medicine classes. I'm not going to present analysis 2, where they might start a second medicine in future, i.e., if they start a statin, they might start an SSRI. If they start an SSRI, they might start a statin. That is all we're including in our model. We're not including other potential sort of use cases. So we've used an assumed test of £96, which has been based on a study where we've micro-costed. So we've basically not just looked at the cost of the test, we've thought what's the test pathway in general practice and used the costs associated with sending letters out, sample collection, people getting rung up with test results, things like that. So that worked out at around £96. We haven't included the cost of data storage, though, in that £96, and that's important because that will add extra. So we've got our 2 medicine class gene pairs, and then we compare that with standard prescribing pathway. The value of a panel test is in reducing the number of medicine switches that someone might have in their current prescribing pathway. Everyone says pharmacogenetics is about improving response and medicine safety. It is, but eventually you will eventually get on a medicine that hopefully works for you. Eventually, it's the number of switches that you take to get there, and the delay in your symptoms being managed that is important. This is where we don't have any data at all on this, and we've had to talk at length with GPs and pharmacists to help us construct this imaginary order of medicines in current practice. So we've said, if you're on an SSRI, the most common one is citalopram, and then you may switch to 1 or 2 other medicines. For a statin, you're starting with atorvastatin, you may switch to 1 or 2 other medicines, and that is what we're representing. So our model structure, this is a huge simplification of what it actually looks like. So we've got an imaginary situation here where we've got a population of people who want to go and see their GP to start a medicine of interest. So there's a decision, you either test them or you don't. If they test them, the medicine of interest could either be citalopram or atorvastatin, and then they get a test result, and then you decide whether they need a new medicine or not, so there's some switch, and we assume what they switch to. That's the short-term time horizon. Then we follow them up for life. If they're on that medicine, how does that extrapolate into lifetime costs and lifetime health consequences? Current prescribing, similar analogy, but you start with an SSRI or a statin, and then you have these medicine switches, and you end up on this same Markov model. So where do we get the Markov models from? We steal them. We take them from NICE clinical guidelines, and so we have reconstructed them, but we've used the evidence that went into the NICE clinical guideline. So this is the model for depression, really simple. We wanted to do a more sophisticated model, but then thought against it because NICE made decisions based on this and thought, well, let's just use that rather than thinking about perhaps some of the more realistic consequences of living with depression, such as dying by suicide. We decided not to include that within our model. I think if we did include it, it would make things look even better than they do already, but we haven't. So it's a simplification, this model. The cardiovascular disease model looks more complicated because you've got to think about more subsequent events that might happen, but in practice it's not that complex a model, and again we've taken it from an existing NICE clinical guideline. So then the bit that we're not looking at today is what happens next, because you need to know that once someone started the first medicine, if we're saying the value here is there is some reuse of data, you need to know how many people then go on to start a second medicine. and when in their lifetime do they start that second medicine, so that they could accrue the benefits from that second medicine. The technical challenge for us trying to model this is if you end up on 2 medicines at the same time, which health state do you model? Because you've got your depression and you've got your cardiovascular disease, and then you start to have competing risks. So what kills you first? That's what we've got to work out effectively. What kills you first? And so we're struggling with that at the minute about how to do it in a not too technical a way. But that is why I'm not presenting those today, because we've not worked it out. So don't ask me about that. So the interim results. First of all, looked at perfect uptake. And you can see when you look at the cost differences, they're small. Quality differences, even smaller. So when we start to do our sensitivity analyses, which we're going to do, it's highly likely that we could start seeing things going in the wrong direction. So some of the assumptions we make might make this not look as cost effective as it currently does, because at the minute it looks ace. It's around £2,000 for quali. So that's a good number, an order of 10 lower than the threshold. Even if you, so we thought, well, let's throw some imperfect uptake, and I'm sorry I didn't see John's talk, but for simplicity, we used 93% again for clinicians ordering the test and then following the test. I think you said it was over 90% if we assume that people get given the medicine that they're going to be on straight away. Even that doesn't mess around too much with your cost effectiveness with the assumptions we've got at the moment. So just to finish, it's a high-profile topic. It's policy relevant. I've really enjoyed working in this area. I've been working with Bill for years, and it's the gift that keeps on giving in terms of technical challenges as well. So it really, I don't dye my hair, but it really is an interesting topic. But we've got to make sure that the economic evidence that we produce is robust enough for informing clinical practice and clinical decisions. It is a complex intervention as well, and the methods of evaluation are going to continue to develop. I think the models that have been done in the past are good, but we could do better with some of the assumptions and the way that we present some of the challenges. It's likely to be good value, but as I've said, we've got some interim, this is an interim analysis, and we want to really confirm these indicative results. But it's the big shout out here. What we really need, if any of you are trying to design a new pharmacogenetic test, please get hold of some current prescribing data. If you could get hold of it, it's gold dust. And I know, I think Podrug's in the audience is going to talk about an analysis that they're trying to do. We need to know what medicines do people start on, how many medicine switches are there, and how is that influenced by pharmacogenetic testing. And if we could get hold of that, happy days. You're not making any assumptions anymore. So my very last slide is just to thank everyone, particularly Bill and John, Jess, I think Jude's in the room, Rachel Elliott. So Rachel Elliott, it was the model that they produced looking at something called a new medicine service. We nicked their design to try and look at pharmacogenetic testing, and thanks to all the public contributors. And I hope I've not gone over time.
Thank you so much, Catherine. And I think it's obvious how complex and how challenging this has been, but it's such an important piece of work. We've got time for 1 or 2 questions from the audience. Stunned into silence. Oh, very good. We've got the data. Fantastic. If there's no questions, Catherine, thank you so much. That was great. Thank you. So we're now going to hear from Vidya, who's going to talk about some of the CYP2C19 testing in stroke, our local stroke service, and give us an update on this. Thanks, Vidya.
Thank you, John. I really enjoyed that talk, Catherine. Thank you so much. I'm glad you are doing these complex and difficult things and not me. I'm going to talk about something a lot simpler, which is probably a reflection of my level of intelligence more than anything else. We did an implementation project to introduce pharmacogenetic testing for patients suffering with stroke. And you will have perhaps heard me present some of this work previously. And this is really just an update and give you the final numbers and data from that implementation project that ran last year. It's going to be relatively short. And hopefully there'll be time for questions, and I'd love for people to kind of think about what the next steps are after we do some of this implementation and pilot work. How do we actually then bridge the gap to routine practice? So yeah, do please think about that and bring your questions. Give you a little bit of background just to get everybody back up to speed, but then really I'll spend most of my time talking about the feedback from the pilot implementation from both the lab testing and the point of care sites. As you will all be familiar, the CYP19 gene can reduce the effectiveness of clopidogrel, which is a very commonly prescribed antiplatelet agent used in heart disease and stroke. And NICE published some diagnostic guidance almost a couple of years ago now, recommending that all patients that are admitted to hospital with a stroke should undergo CYP19 genotyping to guide antiplatelet therapy. We know that if we apply this, and that's what came out in the NICE guidance, there's a benefit to reducing the chance of restroke and further cerebrovascular events. So this was something that certainly from the pharmacogenetics community was received really, really positively, and it was a push towards implementation. Of course, what, as with most guidelines, was not included is how do you actually do this? So it's great writing a nice document, say this is what you should do, but how do you actually do this in practice? And that was the brief that we presented ourselves. The challenge that we presented ourselves was, okay, well, how does the NHS, a large publicly funded healthcare body, implement this NICE guidance as part of everyday care? We wanted to take a real maybe design-led approach or a real-world approach, and wanted to work closely with frontline clinicians to better understand their workflows, their needs and requirements, and work together with them as part of this implementation. So the Network of Excellence was funded to deliver a pilot project, and we worked together with the NHS Stroke Programme as well as the Genomics unit. We selected 4 pilot sites across England with a geographic spread as well as a spread of populations that they served being diverse. I worked closely together with a service designer, which was a great experience. Again, being able to bring someone in who does not have a healthcare background and can ask naive or innocent questions of why do you do it this way, or that doesn't make sense, and indeed is able to pick up things that we would maybe not stop and realize as healthcare professionals because we do it every day. And then someone who comes with an external perspective says, well, why do you have a piece of paper for this, and why do you not have an electronic system, is a helpful constructive challenge. We wanted to have a phased increase in testing numbers, and we wanted it to be iterative. So we started with this approach that we want to learn as we go. We're not trying to design the perfect service from the outset. We want to try to get a minimally viable service going, and then as we go along, we learn and iterate using this kind of agile methodology, which is often described in other industries and perhaps not enough in healthcare. These were the 4 sites. So the lab testing sites were Doncaster, St George's and Exeter, and as you can see, they came on at different time points. I think one of the reflections that I can certainly share is having strong buy-in from the lead clinicians as well as organizational buy-in. It had a significant impact on how this service was rolled out. So Doncaster, for example, was able to get senior hospital executive level buy-in very early. So as part of the program, we did site visits. So we went to all these different hospitals. We walked the shop floor. We walked on the wards. We spoke to the nurses, the patients, the ward clerks to try to really immerse ourselves into that world as part of the design process. And when we visited Doncaster, we went and met the medical director because that's what the stroke team organized. And that made a really big difference in terms of how quickly they were able to then subsequently move on to implementation. Another, I think, important reflection was the importance of bringing together a multidisciplinary team. I think all the sites did that really well from the outset. So we were very encouraging of teams not putting all the burden on either just the medical team or perhaps even senior clinicians. We want them to involve resident doctors. Pharmacists clearly play a significant role in personalized prescribing. So all the different sites involve the pharmacy teams. The regional GMSA pharmacists came and contributed as well at the different pilot sites. And all of that cross-disciplinary working definitely helped in terms of driving implementation in a meaningful way. And we wanted to encourage the clinicians to really think about this from a real-world perspective. So this is not a research study. There's no protocol. There's no consent. There's no research nurse, here to hold your hand or anything like that. This is going to be out in the real world, in the complexities, the busyness of a stroke ward, with patients being wheeled in, with patients going for CT scans, for cardiac arrest happening, in the bay next door. This is where this is happening. So this is maybe not the traditional place where genetic testing has taken place. So it's a real mindset shift for the healthcare professional. So trying to encourage to think about this, how does this work in the real world within a complex healthcare system? So to share with you a little bit of reflections from laboratory testing pathway more specifically, we try to simplify what the steps of the process would be. Again, taking this more kind of design approach, trying to move away from having long documents, trying to think in infographics, trying to think in pictures, was again something that was not necessarily new, but definitely received very well by the teams that were trying to implement this. So they were able to appreciate that there's a challenge around selecting patients, who are the right patients to do this on. There's a process to order the test. How is that ordered? Who orders it? Is it an electronic order? Is it a paper order? Whose responsibility is it? Who takes the sample? Is it a nurse taking the sample? Is it the junior doctor? Is it the phlebotomy team that are taking routinely samples on the ward? How does the sample get to the lab? It's a centralized lab testing process. Who posts it? Who pays for postage? It was a big sticking point. And initially the teams thought, the doctors thought, am I going to have to put it in an envelope and find go and buy stamps and post it? Or how's this going to work? This has not happened before. I think a really big sticking point, we'll come back to that in a moment, is round number 4. How do results come back? How do we receive them? How do we then subsequently action them and make a clinical decision? And how do we communicate with patients? I won't spend too long on this. I think what this is really trying to highlight, and please feel free to ask for my slides later, is that all the 3 different sites implemented a slightly different version of these 6 steps. So these 6 steps are, the universal, but how they then played out in detail on the shop floor was all different. And it was mainly different around the results coming back. Everything kind of up to the sample being taken, the sample going away to the lab was relatively uniform, but how the results came back and how they were actioned were significantly different. I think Exeter probably was the biggest, did it most differently, where they took pretty much a fully pharmacy-led approach. So the pharmacy team on the stroke ward took responsibility of receiving the email with the PDF report. They then entered the report manually onto the electronic patient record. They actioned the result in terms of changing the prescription, whether the patient was still in the hospital or if the patient had left, they would communicate with the GP. And that actually really helped from an ownership perspective. There was clear clarity which professional group and which professional individual was responsible for this. Some of the other sites, the result will go back to the consultant that was on call that day, the consultant who saw the patient 10 days ago when the patient was admitted, a junior doctor who rotates regularly. So you will know all of these challenges. Any of you that work in hospitals, that can pose a significant challenge. So I think that was a really interesting reflection, interesting learning point. In terms of numbers, so we ended up testing in the laboratory half of the project, just under 1,400 patients. As you can see, the relatively elderly population, as you'd imagine, within a stroke population, and 28% of patients were found to have a result that would suggest that clopidogrel would not be as effective. So again, that's in line with widely published instance data, but again, it does reflect that when you do this in the real world, this plays out. So there are 28% of patients that should have received an alternative therapy as a result of being able to get this test. I think from a laboratory perspective, the team worked really hard to try to maximize efficiency. Certainly within the laboratory, the turnaround time was very rapid. The challenge, though, was with the logistics around it. So before the test landed in the lab, as well as when the test result was emailed back to the different sites, how it was then actioned, or the gap between the test being received and the action taking place. We've tried to work with the sites to go back and see if there were any patients who had a test result that suggested they should have a change in prescription, to make sure that that actually happened. And this was difficult because, and again, reflects the kind of realities, plus maybe the fact that this was a pilot. There were kind of clinical leads who took ownership of this project. So in reality, what happened is that even though you had all these like processes put in place, there still were individual consultants who would keep a database to check each individual result themselves, because they were the nominated lead and they felt responsible for the project. They wanted to make sure it went well, even though we were trying to encourage them to let go. This is the real world. Just let it play out. It's fine. It's part of it. It was really hard. So they still wrapped the project in cotton wool to a certain extent. And if there was a patient that hadn't had a prescription change, they would then be able to pick that up or assign someone to go and action that result. So actually, when you look back, I think that, and this is again anecdotal, this is when you've spoken to them and you kind of see that, oh, actually, pretty much everyone had their result action. And then when you speak to them, they're like, yeah, no, it's because I went in on Sunday and like went through the spreadsheet and I found these like 17 people whose things had been missed, and I, wrote 17 letters to the GP and, made sure that happened. Right, okay, that makes sense now. So I think it's difficult to let go of that, and we have to be conscious of that. And I think that, again, reflects very much, it's about how you implement, how do you return those results in a seamless way that takes away the reliance, the dependence on these humans, ensuring or making sure, double-checking all these things. Another important point I'll say is, because the results would sometimes come back to a secretary, or would land in a clinician's inbox, amongst the hundreds of thousands of other emails that they receive, there would often be a gap between them receiving the email and then being able to action it, and then often communicating that to primary care. The way communication often happens still within the NHS largely is letter-based. So a consultant would dictate a letter to say, gosh, I've received this result, and this patient actually doesn't respond to clopidogrel, but I prescribed the clopidogrel a week ago. Do you think you could change it? And then that letter goes to some kind of secretary, who then types it up, and then it goes somewhere else. Then they need to like sign it to make, you'll know, anybody that works in a hospital will know how the process works. So in reality, comfortably, they said on average, probably about 2 weeks between the patient having a sample taken and the result being actioned was probably what they anecdotally felt was the timing. And in reality, what clinicians, when you press them, particularly the stroke doctors, they said, well, this is a service we kind of need to act now. The patient's having a stroke now. They're being discharged now. Ideally, we'd like to have the result as soon as possible. It doesn't need to be within an hour or within a minute or whatever, but within a day would be ideal. So that's something for us to reflect upon. And as you know, part of the project was also to think about, okay, does point of care solve some of these challenges? Is that an alternative way to implement? And in some ways it did. There's some other challenges that came with point of care, particularly around installation, training, quality assurance and validation. You have to, again, if you walk the shop floor, where do you put the box? Where do you put the gene drive system or whatever system you're putting in place? You have to find a space for it. It needs to have various requirements that it adheres to. So it comes with some of the challenges, but having said that, I think from a result being available and being able to be actioned, that was definitely seen to be a big positive that the clinicians felt. So just under 600 tests were done under point of care, kind of similar age. Again, a similar number of patients found to be clopidogrel resistant, if you like, it's around 30, but 95% of prescriptions were changed the same day. So that, I think, does add value or kind of demonstrates that having that result available at the point of decision making and there being less of a time lag, again, reflects, I think, some of the beautiful data that John showed this morning, that there is a lot to be said about that. It is a clinical moment within which that decision is being made. If you miss that moment, it's much harder to come back, or it requires lots of additional time, effort, and as a result, cost, which we often don't talk about, to be able to action that result. One alternative kind of model that we've maybe thought about or explored is there and this is purely for debate, and Bill used the term hot lab this morning, which I've not heard before, but I quite enjoyed that. Is there a everything's hot. Is there rather than it being point of care, rather than being lab, is there a rapid testing model where you have more rapid technologies, but located within hospitals where there are stroke units, for example. So you don't put the onus on the clinical teams being trained, et cetera. It's still within a lab environment. Perhaps it helps with some of the quality assurance and governance. I'm sure there's other challenges with that, and people have different opinions. I'm mainly voicing this as a topic for debate, so I don't know if it's right or wrong, but that's maybe a hot lab model is maybe something else to consider. And ultimately, from a clinician's perspective, they don't really care if it's hot or cold or rapid or whatever. We just need to order the test, we need to get the result, make a decision, look after our patients. Everything else is kind of a lab thing that's kind of outside of our control, which is kind of reflective of the pressures of the clinical front line. Great, thank you very much. I'll stop there.
Thanks so much, Vidya. That was fantastic. Questions from the audience? Yeah, Imran at the back here.
Thanks, Vidya. That was very interesting. Can I ask you about general practice? What were the roles, agreed roles and responsibilities of GPs, particularly in the setting of lack of continuity because of access? Yeah,
really good question. Again, we saw variation. Most lab testing sites had, and it's very good, and it's their own initiative, and again, supported by the GMSA networks, organized meetings with the local GP leadership groups at an ICB level or at a more local level to firstly involve them as the project was being set up. We, as a team, helped them draft letters which would contain the result, including suggestions and recommendations of coding and SNOMED terms, et cetera, that would be relevant for them to be able to code it into local systems. So we tried to work with the primary care community to take them along on the journey, and from a continuity of care perspective, be able to provide them with information in as meaningful way as possible, with the recognition and the absence of truly connected digital and data systems. So ultimately, that's of course what people would readily bring up. This sounds great. Can you, how does this result come to me? Well, it comes to you in a letter. Okay, sure, but how do I, keep track of that information as if it might be relevant for future? The other piece that we heard clearly and we kind of communicated is that we did not expect GPs we didn't expect anyone to individually make a change in prescribing decision. So if there wasn't a letter and there was a question from a patient or an alternative, that the response would go back to the stroke team to manage the clinical decision. In the context where GPs were changing prescriptions, that was clearly communicated in the letter that went out to them to say, this person's had genetic testing, here's the result, based on this, would you please be so kind to switch the patient from clopidogrel to ticagrelor or something like that. I think a big part of this relates back to the digital and data infrastructure and how do we make this more seamless and reduce the burden on this kind of manual communication.
We've got quite a few questions, so we'll take one down here and then...
Great presentation. Thank you. I was just curious, there's two different models. There was GP-led and pharmacist-led. Are there any differences been observed between the two different models at all?
So I think so it's two things. I think, yes, there was difference observed in terms of ownership and responsibility and reliability of going from result to action. And I think the pharmacy-led model had greater success in that. Having said that, there is huge variation within individual NHS trusts in terms of what workforce they have, what individuals feel is within their scope of practice. So there's just variation on what is existing infrastructure upon which you build. So I think Exeter took a very much a pharmacy-led approach. They had a specific stroke pharmacist that worked on the ward, that was there consistently. They had an electronic system that everybody used, a same electronic system everybody used, so they were able to, if the pharmacist put the result on there, it's not like they had a separate prescribing system and a separate medical system or whatever. They put it on the electronic system, then all the doctors could also see it, or the wider healthcare team could see it. So I think it's a reflection partly on the existing infrastructure, but anecdotally, it felt, the pharmacy-led process worked very well.
Great. We'll take these couple of questions just here.
Thank you very much, and thank you for describing so eloquently the treacle through which we wade every day in the NHS. I work at St George's. There was obviously a pilot site. I had nothing to do with it, but this lady here did have quite a lot to do with it. And I just want to ask about what happens next, really, because, we've been offering this test. Now we're not offering this test. We should be offering this test. But what you've described, it sounds tortuous. How can we implement this, and in a structural way? But also, how do we make sure we do implement this, because actually this is going to save lives?
This is the big question that I haven't got any kind of formal answer to, but it's something that I think we should be talking about and debating. I think there are still some implementation challenges, particularly on how the test is ordered. Currently, it was ordered on a piece of paper, which is, again, inelegant and ineffective and risks errors. So there's something about kind of electronic order management. NHS England is working hard to try to make that more accessible and available. But I think the bigger question is about funding and commissioning the test itself. So even if you did sort out some of the kind of implementation challenges and the digital challenges, there needs to be an assigned budget for testing. Stroke is a common healthcare scenario. So this is tens of thousands of tests potentially additionally per year. So it's about, can we find the funding to commission it, ideally at a national level. I don't think this is going to be something that ICBs are going to pick up, certainly not from the conversation that we've been having. We can continue to do little pilots and little projects and find little pots of funding, but I think there's nice evidence, there's implementation guidance, there's clear clinical benefit. So I think that's the conversation that we should be having.
Perfect. One final question.
Yeah, I just wanted to ask a bit more about the agile methodology, and I suppose the methodology in general. As somebody who's an implementation scientist, I wondered kind of how you, I suppose, informed the implementation of it, and like all those lovely quotes you had from the doctors. How did you actually go about collecting all of that feedback? And yeah, because it wasn't classed as a research study.
Yeah. So very briefly, I think one of the advantages that I've reflected upon is me as an individual, as a healthcare professional myself. I'm of course very comfortable in clinical settings. I'm very happy to walk onto a ward and say hi to the ward clerk, or say hi to the matron or whatever, and introduce myself, etc. Emma, our service designer, she's been in some clinical settings, but not often. And we often, I think, as clinicians, forget how alien a hospital setting is, but at the same time, how valuable it is to be there on the shop floor to pick up these insights. So I think it was our combination. We actually have been going around giving a talk about our kind of combination of design and medicine, which I think was really effective. Being able to go into these settings as a team and take photos and pick up quotes and really immerse ourselves. But I think it was that combination of, Emma, roll up your sleeves, use alcohol gel, whatever, being able to do that really naturally is, I think, what worked in this case. So I'm a big advocate of us as healthcare professionals working more closely with people from other disciplines like implementation science or designers or user experience folks, so we can get more of these techniques and methods into healthcare because they're extremely powerful.
Perfect. Very quickly, Ron, and we'll have to move on.
Just a remark there. Okay, so like the implementation of 2C19 testing is like in our hospital going very smoothly. We deliver results within 24 hours. And a lot of the clinicians have now taken up because of the evidence. So that can work, but it should be the local lab that performs the test. And regarding that, I had one remark. You said that the point-of-care testing is much nicer, you get much more adjustment, but the point-of-care testing is more expensive than the lab testing. So I'm not sure if you're now suggesting that Professor Payne should redo all the calculation testing there. So that was my only remark. Thank you so much.
Thank you. Thanks so much.
Thanks very much, Vidal. Fantastic. So I know there were some other questions. I'm sure Vidal will be happy to chat a little bit later. So next we're going to hear from Jess, who's going to speak about, perfect. We're going to hear about a new tool to support the competency framework developed by the RPS and announced today. So thank you very much.
Thank you very much, everybody. My name is Tasso Putu. I'm the chair of the English Pharmacy Board of the Royal Pharmaceutical Society, soon to become the Royal College of Pharmacy. It's very timely, the last session just there, which showed that the pharmacy model was the most effective, efficient model. But the Royal Pharmaceutical Society, I've said this before, takes pharmacogenomics and genomics, the progress that's happening at the moment, very, very seriously. Obviously, the use of these things in the area of prescribing is incredibly important to us, and it's remains a high priority on our work plan. And so today I'm really grateful, really delighted to be able to present or to ask the authors who have worked in collaboration with the NHS England Genomic Medicines Alliance Service to present this competency framework, which will be used for all prescribers in the field of pharmacogenomics. So I'd like to welcome Jess and Sophie up to the stage and say thank you very, very much, everybody. Thank you.
Hello. So what we really want to talk about is this resource that we've developed, which hopefully will support prescribers to be able to use pharmacogenomics within their practice. And I love this infographic from the BPS report from a number of years ago. And what it really talks about, as many of the presenters this morning have said, is that the real value of pharmacogenomics is to inform prescribing. The testing isn't what's important, it's when you change the prescription, that's when you start to accrue that value. And we've got this idea that our standard approach is not working so well, and if we could do this preemptive pharmacogenomic test, we'd get to the right prescription of the right medicine at the right time, which is brilliant, only if the prescribers know how to use that information. If we've got a clinician that doesn't know when to order a test or doesn't know what to do with the result, then we're right back over on the standard approach because they're just going to go to the default of what they're used to. And so we don't start to accrue that benefit. So in my time at the JMSA, I spent a lot of time with my other pharmacy lead colleagues and others thinking about how we encourage all of the prescribers across the NHS to be able to use pharmacogenomics within their practice. And I've got a patient in the middle, and because I'm very egotistical, I'm going to call her Jess. So this is Jess, she's in the middle, and she might encounter pharmacogenomics in a number of different places. I'm not pregnant or making any announcements, but Jess over here in the top left might end up having to have her new baby admitted to a neonatal intensive care unit, and in which case she will encounter genetic testing, perhaps from a junior doctor on the night shift covering the NICU. She may also get diagnosed with bowel cancer, and then she'll be meeting an oncologist to talk to her about DPYD testing as part of her chemotherapy. She might end up having a stroke when she's a bit older, and then there'll be a stroke advanced nurse practitioner who's going to talk to her about CYP2C19. Or she might be very healthy and well, skipping through life, and be offered a pharmacogenomic panel test as part of a health check routinely by her GP, at which point she may then have that interaction of that pharmacogenomics in a number of different places the next time she interacts with healthcare. So that could be in A&E, it could be at her community pharmacy when she's picking a prescription. And so the difference is she's meeting different healthcare professionals in all these different places, and all of them are going to use, hopefully, pharmacogenomics to inform their prescribing. So how do we make sure that the care that she receives is standard and able to use that no matter where that is? So I took this data from the King's Fund. They do at least an annual summary of the NHS workforce in England. And you can see all the different people. And I've circled the different professional groups that can prescribe. That doesn't mean all of them prescribe, by the way. So you can see like 367,000 nurses and health visitors of which, according to the figures from the ICN, about 54,000 will be prescribers. But you can see that there are prescribers, there's GPs, there's hospital doctors, there's pharmacists, midwives, ambulance staff, a number of different allied health professionals, like 14 different professions. It's really hard to get a figure for those. Dentists aren't even on there, but there's about 25,000 dentists, and they can all prescribe as well. All of these different professional groups can prescribe medicines, which might mean they all need to be able to use pharmacogenomics when they're doing that. And they're all trained in different ways. So how do you make sure that they all have the same kind of standard of competence? And we're not talking about really advanced knowledge, but just the basics that a patient should be able to expect from a prescriber. So what is already expected? There's a bit already out there. The Academy of Medical Royal Colleges has got a genomics syllabus, and it does mention pharmacogenomics, but it just says people should be able to integrate pharmacogenomics into their care. No detail on what that might actually look like. The GPHC, who regulate pharmacists, have got something on their initial education and training standards. And then the Royal Pharmaceutical Society produce a competency framework for all prescribers, which is a curriculum of all the things prescribers should be able to do if they're going to prescribe, because we talk about it a lot like it's just, I don't know, writing or quickly typing up a prescription. But there's a lot more to it than that, really. You know, the actual act is very quick, but there's a lot of consulting with the patient, the governance around all of that is all part of that, although it's a very quick action in and of itself. And pharmacogenomics is mentioned, but it's one specific learning outcome. But all of the prescribing professions are either aligned to and use this competency framework for all prescribers, including the Royal College of GPs. So it's a really well-regarded resource, but there's maybe not that much in there really about pharmacogenomics and what that might actually look like in practice. And 2 years ago now in Liverpool, Emma Groves and I, Emma who's on mat leave at the minute, stood up and talked to everybody about what we thought needed to happen. And we would have said that we've got people who learn in proactive and reactive ways and all of these different things. But what we said is the people who are going to learn need to know what it is they need to learn to be able to do their job. And you cannot do that if you haven't told them what the competences are. So what we focused on for this piece of work is defining what it is people need to be able to do when they're prescribing and putting that into some kind of pharmacogenomic context. And so we came up with this work package, which we were funded to deliver. And it's really about developing a resource to support prescribers, whether they're current prescribers or soon-to-be qualified prescribers, to use pharmacogenomics, to look at the things they're already supposed to be able to do to be able to prescribe and put a bit of a pharmacogenomic lens on that, and to explore whether there are any new things, new competences that people need to be able to do as part of prescribing. And we really wanted to model that on the existing competence framework so that it made sense, so that it is something that's already being used and out there amongst prescribers when they're being qualified, and that those things could be used alongside each other. We felt very strongly that the audience wasn't to be pharmacy. We did talk about doing something just for pharmacists because we're both pharmacists, but we decided that actually we're a relatively small proportion of the prescribing workforce overall, so we wanted this to be truly multi-professional. And so we partnered with the RPS to develop a multidisciplinary expert group to try and develop a resource that could be used and implemented for multi-professional audience. And so my slightly upside down timeline will tell you that we started this work with the RPS in January last year. We appointed a lead author, who's Sophie, who I'll hand you over to very shortly, and a chair, who's Jude Hayward. We established a task and finish group with multidisciplinary representation, had a series of meetings. The resource went out to consultation. Hopefully you would have seen. I know some people have responded to that consultation in January, and then that resource has been signed off, and delighted to say it has been launched today. So I'm going to hand over to Sophie, who's much better equipped to tell you all about the resource.
Thank you, Jess. I just wanted to say how grateful I am for my role within this sort of very collaborative piece of work as well. So to focus in more on the resource, with regard to the purpose, as Jess has mentioned, is to support prescribers across all disciplines to build and expand their pharmacogenomic competence, to ensure they're safe and effective prescribers with the use of pharmacogenomic testing, to improve patient outcomes. It really was for all prescribers, so we were focusing and exploring what it meant for trainees as well as registered prescribers across the UK nations, to be inclusive, as we're aware that prescribers move around the UK and practice and train in different parts of the UK. The instances where this resource and the purpose of the resource to be used, for example, would be around self-assessment, when somebody's expanding their scope of practice as a prescriber, but also returning to practice, for example, and also with regards to providing evidence as training to become a prescriber, as well as regulators, educators, and professional bodies to utilise the support document with development of curricula and standards, also organisations implementing governance around the prescribing practice, and also for individuals developing their portfolios with regards to revalidation, etc. So it's be used by any prescriber at any point in their career to underpin their professional responsibility, but also really keen to ensure that it did not seek to disadvantage any professional prescriber. So the scope of the resource, which is a little bit repetitive, but really just highlights the main scope that we work into, is, as Jess has said, to complement the existing competency framework for all prescribers, which was launched back in 2021 by and is hosted by the RPS. Also for all prescribers of all professional background or setting across the UK. The scope was to contextualise and reflect on different areas of practice and levels of experience, but also to reflect the key competencies and skills needed by all prescribers to use pharmacogenomic testing in the real world and in everyday practice. And to accommodate and ensure that we're not only thinking about different professions, but also different types of prescribers, so independent prescribers as opposed to supplementary prescribers, so we're inclusive to all. And the main sort of focus of the scope was to ensure that this was a sort of an entry-level baseline expectation for the use of pharmacogenomics within prescribing practice, but obviously also acknowledging that there may be a requirement for advanced competencies in the future as pharmacogenomics becomes more embedded within a service or pathway. So then obviously overarching benefits of this piece of work is to standardise pharmacogenomic education and competence across professions, not to provide an educational resource in its completeness, and also to support the design and validation of educational prescribing programmes. Apologies, the text is a bit small there, but other applications, as you can see here, there are many others around professional organisations or specialist groups that are looking at levels of prescribing competency, and also discussions with a multidisciplinary skill mix and teams around pharmacogenomic prescribing competencies. But I think one really important factor, and it isn't any sort of consideration that it's last on the list, but really to inform and assure patients and carers about the competencies of a safe and effective prescriber in relation to pharmacogenomics. Limitations were that obviously prescribers were not expected to have knowledge of pharmacogenomic tests outside of their individual scope of practice, and that was something was reiterated during the task and finish groups on regular occasions, and also to ensure that, to make really clear the limitations around the fact that this document is really to support individuals to develop their pharmacogenomic competence by adding additional context to the existing competencies for prescribers, but that doesn't mean that where we didn't add additional context within the document, that the pharmacogenomics was already included within that point for potentially requiring new knowledge, skills and behaviour to maintain competence. So I think you can just about see hopefully a sort of a screen grab of the document. This is the web version. There's also a PDF version. We followed with regards to the structure of the document. So we followed and sort of reflected on the competency framework for all prescribers, as I said, which is already in existence. The document is divided into two domains, as is the existing document, domain 1 and domain 2. Each domain is introduced as it very briefly, and then the common themes summarised at the start of each domain related to those competencies within the domain. We felt that that was needed as we were moving through the task and finish group sort of exploration with a wider group, that lots of the same issues or the same sort of competence or aspects were coming up again and again. So rather than to repeat them throughout repeatedly, we put them at the start of those domains to give a sort of brief summary and to explain them slightly more than we were able to throughout the document. Then to go into the underneath the domains, the competencies as within the original document are scattered within those domains, and you can see from the left, or you will be able to see from the left when you look at the resource, that those are the original supporting statements which are used to enable you to achieve that competency. So to go through into more detail, and to the right we utilise those supporting statements, moving through them one by one, to put that sort of context, which was exceptionality that was needed for pharmacogenomics within that. We also added 5 case studies, which wasn't an exhaustive list, and we could have gone on and on and on because there was lots and lots of examples and case studies suggested throughout the process. But again, it was felt that they probably didn't need to be any more than 5. They were purely there to bring the resource to life, to really make it applicable and people to understand what this really meant for their prescribing practice, and also mindful of the need not to include any sort of suggestion and points around commissioning and access to testing, because obviously the differences across the UK, as well as potentially within different regions within England, for example. There's also competencies linked here back to the original resource that, again, further explaining where there's a potential ability to obtain that competence. And then finally then, I was just going to hand back to Jess then with regards to the impact, just because my eyesight, I'm not able to see those points.
Yeah, apologies. All the font looks a lot smaller when it's on this big screen with the bright light, doesn't it? So thanks, Sophie, for doing that quick run through. And I think, we only have such a short time today. I've got QR code in a minute. Anybody who's interested, I recommend you just go and visit and you can look at it in your own time. But what we really feel that the impact of this resource will be is, first off, it aligns pharmacogenomics to mainstream prescribing competence so that it's something that when people are prescribing, they're able to think about straight away. It outlines the expectations for prescribers, especially as pharmacogenomics. I keep saying people don't change their scope of competence, but pharmacogenomics is going to start coming into it. You're a stroke prescriber, you're not using it, and all of a sudden that you are. So what are the things you're expected to do? Because those might be the things that make you go and use some of those educational resources that are out there. It helps to facilitate inclusion of pharmacogenomics within the curricula of these prescribing programs, be they undergraduate or postgraduate qualifications, because it's not just one learning outcome, it's how pharmacogenomics can be interpreted against all of the other things that you already have to do. It then enables a bit of a gap analysis, so we can look at whether the resources for the existing workforce actually help them do the things they need to do with pharmacogenomics. And obviously the point of all of that is to hopefully improve patient outcomes through this standardised approach to prescribing using medicines optimisation. So I now have the lovely job of thanking our team, most especially Sophie as the lead author, but also Jude Hayward as the chair, the team from the Royal Pharmaceutical Society, and I'd also like to thank Wing Tang and Ellen Jones, who were there at the beginning, no longer working with the RPS, but they were key to bringing this project team together, and everybody in the Northwest GMSA programme board as well. If you'd like to go and visit it, I'm thinking there's a lot of people in this room that maybe aren't prescribers themselves, but they're in networks that they'd like to be able to share it with it. It went online today. I'm very sorry. I will go back. I can see some people that were trying to get the QR code. And then the next thing to say is that for people who do want to share this further with their networks, we're going to have a webinar in a couple of months' time, which again, I appreciate if you can share to let people know how they can actually use this and what the point of it all will be as we try and mainstream this as part of prescribing. So thank you all very much. Thank you very much. Have you got time?
Yeah, so thank you very much for that. That was absolutely brilliant to see this resource. We've probably got time for 1 or 2 questions, if there's any in the audience. If not, I'm sure you've got the links on here, and the team will be here to chat to you afterwards. So thank you very much for that. Perfect. So we'll move on next to Dr. Vicky Welsh, who'll be talking about the use of pharmacogenetics in care homes. I realise we are running behind. We will shorten the final session, so we'll make sure everyone gets off in time for their trains, so don't worry too much.
Hi everybody, thank you. I'll keep this short and sweet to catch up some time maybe. So thanks, I'm Vicky, I'm a GP and researcher at Keele previously for a long time, now at Brighton and Sussex Medical School. I've been working with a team trying to get together some research looking at rolling out pharmacogenomics in care home settings. When I came this morning, I was really confident that I had a fairly clear idea of where the end point was going and what it was going to be in a few years' time. But as my kids would say, my mind's blown today, particularly with the health economics. I can't imagine how that might work. But anyway, I'll tell you a bit about where we're up to at the moment and what our next steps are. So we've called it OPUS, which is Optimising Prescribing in Care Homes Using Pharmacogenomics. We've got a team of people around us, and this is a pre-programme development grant from the NIHR. So why we're looking at care home settings, current research, certainly in the UK, isn't specifically focused on care homes. There's been a few international studies that have demonstrated there probably is some value in looking at this, but it's highlighted some real difficulties with implementation, particularly changing clinicians' behaviour in prescribing. In the UK, we've got almost 400,000 residents of care homes, well, in England and Wales. I'm talking specifically for this project, older adults living in care homes including residential and nursing settings. As we know, multimorbidity is really common with increasing age and frailty status. And that goes along with polypharmacy as well. And this is even more prevalent in our care home populations. Estimates show there's probably around 80% of older people residing in care homes taking 5 or more different medications. The studies that have been undertaken in Canada and Denmark have shown that an average of 4.6 drugs per person that are potentially amenable to a PGX intervention. We know that our care home residents are more frail and therefore more susceptible to the adverse drug reactions and poor outcomes. We've also heard today about this equitable genomic testing. I really believe that this should be at least an option for our older people who are taking all of these medications. So that's really why we wanted to get this going in care homes. Also, we've got this commitment from various different sectors, including the British Geriatric Society, about seeking a commitment to ensure research is inclusive of advanced age and frailty status as well. We've heard about this real world research, and hopefully that's what this will be. So the question is, would pharmacogenomic informed prescribing actually make a difference in our care home residents in terms of reducing adverse drug reactions and these associated poor outcomes? There's a question about what poor outcomes are, which I can't answer now, but that's something else we need to look into as well. Sounds like I need to have a conversation with Martin. So the objectives for our programme development grant will be delivered in 4 work packages. The first is a quantitative analysis using the SAIL data bank, and that's to establish the current prescribing epidemiology of medications with these known drug-gene interactions within a care home population. We've got loads of evidence about polypharmacy in care homes, but we don't actually know what the epidemiology of these specific drug-gene interaction medicines are, so we'll start with that. Alongside that, we're running some qualitative work to understand the practical and ethical components of potentially delivering this pharmacogenomic informed prescribing in care homes. We want to develop this network of experts to help us think through how we might start to answer that clinical question, will PGX make a difference to our care home population. And then the end point of this pre-programme development grant is to hopefully design a prototype care pathway that we can then go on to test as a complex intervention in a future programme grant. Underpinning all this is our public engagement work. We've got a PPIE group and starting to get our community conversation groups together. And our timeline, hopefully we've finished our analysis. Now we've got our ethics approvals for everything in September with a grant deadline ambitiously of December, but possibly in early 2027 with some outputs after that. So just very briefly, the current prescribing epidemiology, it's of all the drugs we've just heard about today, so I don't need to go through those with you. But we're looking specifically at establishing the prevalence and incidence of prescriptions in adults aged 65 years and older residing in care homes, stratified by various different characteristics. And then we also want to look within the population who are taking those index medications, deprescribing patterns, and the funder was quite keen on us in our second round of review comments to include some outcomes. So we've got hospital admission and increasing frailty score after an incident prescription of these index medications. Our qualitative interviews, briefly, so we've got 36 interviews. We're confident we'll do this all right because we've done some good care home research before. We've got a really good Enrich support. I don't know if people know about that. It's the Enhancing Research in Care Home Network with the NIHR. They're really good. So we should be able to get our 36 interviews there. Covering... we're hopefully not going to go over all the work that has already been done in the network, but specifically looking at how this is going to work in care homes, particularly the ethical challenges about knowing this information. What does that mean for relatives? How can we do this for people that can't consent for themselves? Can we even do that? There's so many things to think about. Also a little thing in there about information needs as well, specifically to this care home staff group and patients and relatives. We'll use some reflective thematic analysis. And then the final thing is this expert group. So I've already asked a few people, thanks Bill, and thanks Catherine and other people that have agreed to have a conversation. We need some expert help to try to think through what a complex evaluation might look like for a programme grant. So that's one group that we need to be getting going. And then we also need a stakeholder group for the PDG, but also going forwards for the next step as well, which will probably be over the next sort of 3-4 years or so. So we've got a few people interested, but if anybody is particularly keen to get involved in the conversation about care homes, frailty, panel testing, are we going to do this when people come into a care home? So we've got this information for a medication review. Is it going to change deprescribing? Why have we got all these guidelines and we're still prescribing? There's so many things in there. So if you're interested in getting involved, you can just about see my email. Just reach out or scan the QR code and we'll be in touch. It'll be 3 meetings an hour ago. Thank you.
Thank you so much. Any questions from the audience at all? While people are thinking... Oh, yeah, Catherine?
Can I ask a question? This is to give you some thinking time. So in terms of... these are private care homes?
That's exactly a problem. It's going to be like herding cats because each care home is run differently. Some are private, some are NHS, some are mixed.
Okay.
Yeah.
My question was about who pays for the test.
Yeah.
Is it the care home or is it the NHS? And from the economics point of view, that throws in another little challenge for us.
Yeah, absolutely. And I mean, we've got that on our topic guide to ask in interviews, but I don't know how many care homes in the country are privately owned compared to NHS and continuing healthcare. I mean, I can't even think, but important. Thank you.
Great. I had a really quick question. It sounds like you maybe answered it slightly at the end, but so you're not quite sure yet what your intervention will be, whether it's around de-prescribing, medicines optimization, or around incident prescription? There's still work to be done to define exactly how that pharmacogenomic might work.
Yes, well, there's two options, and we may end up testing both. So one will be testing for new prescriptions, much like you've done for Progress, but just in care home. But I think the real value is probably going to be in supporting de-prescribing. So that will be the panel testing on entry to care home, and then take account of that in medication reviews.
Okay. Thank you so much. That's brilliant. Great. Moving on, very happy to have Munir here, who's going to give us an update on the work that the CERSI has been doing over the past year. So thank you very much, Munir.
Okay, thanks very much again. So we presented 6 months ago, so hopefully many of you know what the CERSI is. And some of you will have been at our workshop in January on the CERSI. So I'm going to give you a very quick run through. We were running out, we haven't got much time, but tell you about what we're trying to do over the next 6 months and so on. So this is the structure of the CERSI, 5 different work packages. I'll go through those. The aim when we started is really to work with the regulators to develop proportionate, forward-looking, inclusive and responsive regulatory pathways that enhance innovation. So work package 1 is about guidelines, and we have published the clopidogrel guideline, SUP2C19, the carbamazepine guideline that Lucy Galloway led has just gone for publication to British Journal of Clinical Pharmacology. ACKR1 is following, that's Elvira led that, irinotecan UGT1A1, Damisha led that, and that's hopefully going to go out to publication very soon. And MTRNR1, that's Bill and John led that, will be going through to publication. It's a very involved pathway to develop these guidelines, a lot of work, literature, and then sort of a representative committee, which is very sort of sometimes some of the committees are over 20 people in terms of number, and then we send out to external consultation as well, so we get input from lots of different people to make sure that these are fit for purpose. So we are getting bridging funding to continue the CERSI beyond the 1 year. So for 6 months from the MHRA, hopefully we haven't heard yet, but hopefully in the next week or so we might hear. So what are we going to do? We are going to go on to do some new guidelines with at least 2 completed in the next 6 months. We have started on the SSRI antidepressants. We'll go on to tricyclic antidepressants, antipsychotics, TPMT and NUTT15. If you look at the pharmacogenomics information on SMPCs, it is out of date. So what we are trying to do is to use the clopidogrel guideline as an exemplar, work with MHRA to see how we can modify the SMPC for clopidogrel to bring it up to date. And the other aspect that we're working on is really to develop new UK-based pharmacogenomic guidance for industry. At the moment, the UK uses EMA guidance, which was published in 2012 when we were part of the EU. The EU has just launched a consultation on new pharmacogenomic guidance. That will be EU guidance. We're no longer part of the EU, so we will need UK-based guidance and so on. One of the things that I'm very keen on is to actually have a separate section on pharmacogenomics in the SPC. We will be the first country in the world to do that, if I can persuade the MHRA to do that. Also, we want to address PIL standardization, work package 5, and we'll come back to that. Work package 2 is very much industry, led by Jackie O'Brien and Mark Wigglesworth, literally focusing on the fact that why UK is the place which invented sequencing, but why is it that whenever somebody sends a DNA sample to a company, it all goes outside, the DNA stays outside the country, we only get summary data back, all the raw data stays outside the country and so on. So why isn't it all happening here? And part of the reason, apart from investment opportunities here compared to the United States and so on, is that we just, our regulatory pathways are really very complex. The number of steps industry have to go through to be able to get a process which goes from getting a request to actually delivering the result is hugely complex, and there's often not enough expertise in companies, particularly when they're small, medium enterprises, but also not enough investment at the moment in order for them to be able to do that. So Jackie and Mark have been working very hard on this and developing solutions for industry. They worked with the MHRA to try to streamline that particular pathway using a test case in the laboratory test case, which is a pilot assay using a Thermo Fisher platform and run the regulatory process and provide the regulatory roadmap. When I and many of you here will apply for ethics approval, you go through the IRIS portal that gives you the ethics form. It also allows you to be able to directly apply to the MHRA. So it's made our life much easier since the IRIS portal was introduced. So I suggested to them, why can't we have a pharmacogenomics portal for industry? And they have done the initial architecture of that, and they are certainly looking towards developing that further, and so they can have a pharmacogenomics portal. So everything you need is on one portal, rather than having to go to 20 different places to be able to fill out the forms and so on. And Jackie's also formed this UK Industry Pharmacogenetics Network. So next 6 months, they are going to have recommendations for what a regulated commercial laboratory infrastructure should be to develop pharmacogenomics at scale. They are working towards the regulatory portal. It's going to cost a lot of money. So they're looking for funding to be able to do that. And the report on the impact of industry regulatory science activity that's been undertaken in the pharmacogenomics CERSI, and see how that can support business growth and development. And again, horizon planning as well, in order to take things forward. So work package 3 is led by Maria Sakharoglu and Emma McGovern. And really, this is about education training. When the report came out from the chief scientist, it was mainly CERSIs were set up to upskill regulators. So the platform has been developed really to initially for regulators, but it can be used by anybody, and hopefully will be used by lots of people, including clinicians within the NHS from different professional areas and so on, but also hopefully by students as well. So a portal has been developed with the British Pharmacological Society. Hopefully many of you have been on that and have looked at it. And so we are getting a lot of traction at the moment in terms of numbers of people actually accessing this particular portal. So over the next 6 months, there are 7 modules have been published so far. Over the next 6 months, the idea is to publish at least the 2 educational modules, develop closer links with GE notes, and explore the use of pharmacogenetic content created in academic institutions. A lot of us give a lot of lectures. I have lectures for pharmacogenomics in my university. Sandosh has highlighted that he does that in Glasgow, and very many other people do. So we're going to start looking at seeing whether actually the content there could be repurposed instead of us having to reinvent the wheel and to put on the platform, so that we can provide a resource which is much wider and much broader than it is at the moment to be able to do that. And we are also improving the functionality of the training platform. Work package 4 is health economics. Dufric Hughes and Chris Sampson. Chris is from the Office of Health Economics. And again, I won't go through this since I'm not a health economist, and specifically since Catherine is in the front row. The idea here is to think about 2 big questions. Is wider uptake of pharmacogenetics cost effective? And what is the value of wider uptake of pharmacogenomics to the UK economy? And the wider uptake, what they mean by that is more tests, more genes, more drugs, and more people. And so Dufric and Catherine have been leading on the cost effectiveness of panel testing and different methodology than Catherine's used, and larger number of drug gene panels. But again, they presented the data on that. I don't want to sort of present their specific data, but again, it was cost effective, not too dissimilar actually in terms of the values, Collie adjusted values that Catherine showed as well. The second aspect is much more wider. What is the value of investment in pharmacogenomics to the whole economy? And Chris Sampson's been leading that. And the strapline that I want from that is how much money you get back in terms of after investing £1 into pharmacogenomics. And Chris tells me that it's £1 invested leads to about 17p return on investment every year in perpetuity. So after 5 years, you've paid for it, and after that, it's all profit. He's working on that still and finalizing that. So I'm hoping that's going to be the kind of strap line that we get from that. Next 6 months is dissemination of health economic findings. We are going to have a parliamentary reception on this health economic findings that hopefully can persuade politicians to put some money into pharmacogenomics. We're incorporating health economic data into Work Package 1, obviously, guidelines. And then we are starting to look at the economics whole genome sequencing, particularly if that's going to become the standard for the future. And so it's very future focused. Work Package 5 has been led by John and Ramona, who are in the front 2 rows, and involved the development of patient voice panel using Vocal in Manchester, looking at direct-to-consumer pharmacogenomic testing and assessing pharmacogenomics data presented in PILs. And I'm just going to present something on the third aspect, which is a slide from John. And John and team looked at SPCs where there was some pharmacogenomics information, 79%. Both SPCs and PILs are legal documents, and the PILs should really reflect content the SPCs, but although 79% of SPCs contain pharmacogenomics information, most of that pharmacogenomics information is rubbish actually, but never mind. We can sort that out some other time. And then the PILs, only 32% actually had pharmacogenomics information. And the reading age of the pharmacogenomics information was 18 years when you consider the reading age for UK adults is 9 years. And John has written a white paper which has been sent to the MHRA to consider how to standardize that kind of information. But in the next 6 months, the idea is to develop a best practice consensus framework defining both when pharmacogenomic information should be included in PILs and how it should be communicated in a clear, proportionate, and accessible manner. Clearly, we work together in terms of Work Package 1 and Work Package 5 in terms of sorting out the PILs and changing the guidance for industry. And obviously, the patient public engagement panel is extremely important, and John has plans to be able to move that to a communication advisory panel. So this is the team. Thank you very much. As I said, I'm speaking for all of the people who've done all the hard work. We worked hard over the last year and achieved a lot in 1 year, actually. And I'm glad that we've hopefully got 6 more months funding and then further funding, hopefully, from Network Excellence to continue with some of these aspects. Thank you very much for your attention.
Thank you very much, Munir. Any questions at all? It's obviously a huge programme of work. Any questions about the CERSI itself or any thoughts?
They ask questions at the workshop. And
exactly.
Yes.
Yeah. So no, thank you very much, Munir. That was absolutely brilliant. Thank you. And this has been an absolutely jam-packed session, and so we've got one final talk before we have a very short break. So very pleased to have Patrick Dixon and Cynthia Wright-Drakesmith talking about accessibility of pharmacogenomic data within the Our Future Health cohort. Thanks, guys.
Thank you, John, and good afternoon, everyone. So this is going to be a very quick overview in 2 parts from myself and Cynthia. We're not so far from the Charles Dickens Museum, and we're going to talk about a study we finished, a study that we're doing at the moment, and a study that's yet to come that we hope get funded. And these studies are in CPRD, Clinical Practice Research Data Link, which Cynthia will talk about in the second half of this presentation. I'm going to talk about a study recently completed in Our Future Health. So for those of you who don't know, Our Future Health is this huge biobank scale study that's aiming to recruit 5 million adults from the UK. So that's 10 times bigger than UK Biobank, with which you might be familiar. We got expedited early data access to the data last year. And in the June 2025 data release, we were able to study just under 1.8 million adults and their baseline questionnaire. So at this point, their imputed genetic data hadn't been linked. We didn't have prescribing or dispensing data. So we did a study on self-reported pharmacogenetic medicine use. And we looked at the 4 genes that John has mentioned already. This cohort was 57% female, mostly white, average age of 53.1 years. We looked at drugs connected with those 4 genes for which there was CPIC level A evidence. And then we look for responses specifically mentioning those names in the baseline questionnaire, which is filled in by all participants. So 25% of that 1.8 million cohort reported use of medicine groups related to those 4 genes. And again, it'll be no surprise, given those 4 genes, it's the same drugs we've been hearing about all morning and all afternoon. So statins, tricyclic antidepressants, SSRIs, and PPIs were the most common classes of medicine reported, and it was a little idiosyncrasy of the baseline questionnaire that we couldn't necessarily identify specific drugs, but we could identify classes of drugs and medicines. Use of pharmacogenetic medicines is more common in females and at older ages, although at the oldest ages, men became more likely to use these medicines. This is self-reported diagnoses, so again, a little quirk of the baseline questionnaire. This question asked, have you ever been diagnosed with one of these conditions? And then we ranked it by how prevalent use of pharmacogenetic medicine was. So the top few hits, again, no surprise, anxiety disorders, and these are the names in the questionnaire, not our choices: bone and joint conditions, depression, cardiovascular disease, gastrointestinal disorders. We looked at concurrent use, and again, another quirk of the questionnaire. The participants in the cohort were asked, are you using at the same time particular medicines? So for example, the most common concurrent use was SSRIs and tricyclic antidepressants, which wouldn't usually be prescribed at the same time. So perhaps there's a degree of response bias or confusion. Perhaps people had received tricyclics in the past, were moved on to SSRIs, but they're reported as if they're using it at the same time. Also, you might notice the 4th most common one, SSRIs and PPIs. When we shared the first draft of this paper, Bill pointed out that I think PPIs can inhibit CYP2C19, which might lead to phenoconversion of the SSRIs. So all of that was self-reported medication use with all of the quirks, idiosyncrasies. What came out just as the paper was accepted in December 2025, so just about 10 weeks ago, was the latest data release, which not only has 200,000 more people in the cohort, but they've completed an imputed data set for about 550,000 people. So I think it's 160 million variants have been imputed. And they've linked that to dispense medication in primary care records. So not prescribing, not self-reported, but actually dispense medication use. And this will obviously be a tremendously valuable resource to study and address some of the questions that will be coming up all day. So this is the future study. We've applied for funding. We're applying for funding now, and we'll probably have to keep on applying for funding to do this. But we have set up a simple pipeline in our Future Health and the TRE. We're familiar with the data, and hopefully we get a chance to do this at some point. I'll now hand over to Cynthia, who will talk about the CPRD work that we're currently engaged with right now.
Hi, I'm Cynthia, and I think the title of my part should just be more of the same. So this is our CPRD. It's a project. It's funded by the NIHR. It's really a straightforward project just to look at the scale of pharmacogenetic prescribing in the UK. We're looking at our favorite 4 genes and 93 distinct drugs which were associated with guidance, which seems like a lot, but some get double counted if it's codeine or codeine with paracetamol. So the demographics are pretty much in line with the UK population, which is good. This is the distribution of age of our patients at the index date. And can you see the pink bar? Yes. Okay, so we're pretty happy with the graph in the bottom right-hand corner because it parallels what Parrot showed in the Our Future Health cohort, with women being more likely to be on a pharmacogenetic drug, which is nice because they're 2 different studies and done 2 different ways in different populations. We have just over 800 million prescriptions in this study, so our population is 16 million people. So yeah, it's over 800 million prescriptions, and this is the breakdown by gene. I was surprised how many statins people take if you look at the 3rd bar. And to look at that data a bit more closely, so for CYP2C19, you basically have your PPIs and your antidepressants and clopidogrel, and then for CYP2D6, it's basically pain medication. And you can see the distribution of who's taking that underneath the graph, with women being more likely to consult about mental and physical pain. And then for CYP2D9, it's basically warfarin and ibuprofen. And then we have our statins on the right. And happily, we don't have, young people on statins and young people on warfarin. So the data all looks good. We also did an analysis by long-term condition. And as you can see, the people who have cardiovascular disease are taking their statins, which is good. So this is all just, sense checking our data. We're very happy with how it looks. It makes sense. And the questions that we are addressing are basically, we're going to do an analysis of ethnicity. We're going to examine potential inappropriate prescribing across ethnic groups. We're going to look at drug switching, investigating switching patterns following pharmacogenetic prescribing. We're going to do economic analysis and healthcare use of consultations, and we're going to do a bit of machine learning to identify patients who would benefit from prioritized rollout. Thank you.
Thanks very much. So any questions from the audience about the approach they've taken or about the proposed work? It's obviously an incredibly powerful cohort. What's the readiness of the Our Future Health cohort for analysis by researchers at the moment? Is it kind of widely accessible with regard to the genetic data? Because I know when we originally looked, it wasn't available. Is it ready now?
Yeah, so it's not widely accessible in the sense that you do need to go through an application process, and I think it's begun to open up. And as far as I know, the imputed data set is available now if you follow the application process. So I think you could start as soon as you're given approval to access it. At the time we were doing this last summer, it wasn't available. Also, access wasn't generally available. We had a special scheme that we got onto to analyse it. But I think they would be keen for people to be applying and to use it now as it stands.
Yeah. Fantastic. Any other questions at all? Yes, so right at the back. Yes. It was Emma. Hello, Emma.
Sorry, thanks so much. Looks like wonderful work on such a big scale. I just had a question about the CPRD work, because Emma Baker's group at St. George's did a longitudinal study with CPRD meds looking at a similar question around the epidemiology of pharmacogenomic drugs and found very similar numbers, probably 6 years ago or so. So obviously we just got a headline view, but I was really keen to hear sort of what different aspects this study might be looking at. Thank you.
I'm sorry, I didn't understand the question. What different aspects?
Sorry, I was just wondering sort of what further aspects you were looking at that would contrast from their study landscape within CPRD.
It's really more just an updated study.
Oh, okay. Thanks.
Thanks.
Thank you.
Okay, thank you very much for that. Thank you. Perfect. So what we'll do is we'll take 15 minutes now. If people come back at 20 past, grab a coffee, grab a comfort break, and then we'll have an abridged session updating on Network 2.0. Thank you very much to all the speakers. It's been a brilliant session. Thank you.